Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from GlaxoSmithKline.
Welcome, everyone. Thank you for being here. Obviously, we're excited to have you here so we can talk about RSV vaccine guidelines. I'm loving the name, the RSV Rundown. My name is Dr. Alok Patel. I'm a pediatric hospitalist at Stanford in the Bay Area. I also work as a medical journalist and contributor for ABC News. Telling you all that because I swim in RSV every season in the Children's Hospital, and then I go and talk about it every year on television. And I am intimately and passionately embedded in making sure that we have a brighter future for millions of people across the world. So I sincerely appreciate you all being here. So with that being said, I reiterate this again. I want to make sure that everyone is participating. Throughout a couple moments, I will be running around in here, getting people's opinions. There are no wrong answers when it comes to this. We're just trying to have some fun dialogue. I'll pass it over to both of you to introduce yourselves and then pass it on to Jeff to take it away.
All right, my name is Abby Olulade, and I'm a family medicine physician in San Diego at Sharp Sealy, and I'm the Chief Impact Officer there as well. And I also work in media like Alok, and it's really great to be here.
Thank you. Good evening. My name is Jeff Goad. I'm a professor of pharmacy practice at Chapman University in sunny Southern California. And I'm also the president for the National Foundation for Infectious Diseases, so representing pharmacists there. And so this is our program overview. We're going to talk a little bit about the current guidelines and recommendations for RSV vaccines. So I know there's a lot of questions around there, and especially some new questions coming up. Strategies for discussing RSV vaccines, especially in light of changes. How do you actually communicate that to patients? And then strategies to address parents' or patients' concerns and questions. And lastly, some best practices to improve vaccination rates. The goal, of course, is a vaccine has zero efficacy sitting in the refrigerator. So we need to figure out how to get it into people's arms. Okay. That's our disclaimer. So this is our agenda. We kind of promote it in the video, but we're going to go through and we're going to really interact with the audience. Absolutely, that's the plan. But we're going to make sure this is very interactive because you have a lot of experience that we want to be able to share with everyone else in here. I think that's probably the best. When you have a bunch of people together that have a shared experience, you got to get it out. We'll do that. So that'll be some of our interactive sessions, and then we'll end it up with some, I guess as Alok said, some target practice up here. Ask the experts. So we'll take your questions. All right, let me turn it over, and
There we go. That was a really great intro. I appreciate it.
I'll throw it over to Abby.
All right. So we'll talk about some breaking news on RSV. So talking about RSV always feels like talking about breaking news because COVID and flu took the spotlight away from RSV for the longest time. And until about 2 years ago, with the advent of the RSV vaccines, which Jeff is going to be talking about later on, that really brought RSV into the public consciousness, and for a very good reason. And in fact, a lot of the technology that was used in RSV was built upon the COVID vaccine technology. So that was part of why we had these breakthroughs that are great. But if you're anything like me, when you're talking to patients about it and you say, hey, have you gotten your RSV vaccine? They just give you a blank stare and they're like, what on earth is RSV? I get that quite a bit in the adult population. And one of the flights I was on coming over here, there was an older couple sitting next to me and they were peeking over and looking at my slides and they said, what's RSV? We've never heard of it. And so that's why it's important to be able to talk to patients about it, because a lot of people actually are not exactly sure what it is. And so very basically, it's a virus, just like Alok was saying at the beginning, and causes very mild symptoms for most people. Most people are going to get better from this, but it's important to remember that it can really cause really severe illness. So those smaller airways, That's what bronchiolitis is. It can really affect those. We also see people get pneumonia. We see people get worse in terms of their pre-existing conditions from it. And in terms of the age range that is most at risk, the very young and older population. And that is similar to what we know about a lot of respiratory viruses. But it's very important to remember that we really do need to protect against it. And it does have seasonality, again, just like COVID and flu. So Alok and I can probably set our watches to when producers start to call us to say, hey, we need some sound bites about this triple-demic. That's a buzzword that, of course, is now being repeated over the years. They're talking about COVID and flu, and the last one is RSV. We do see that it starts to peak in the fall and winter, and we even still see it this time of year and sometimes all the way until May. But it does have seasonality, and that's important because you do want to provide that vaccination and protection based on that timing. And then in terms of symptoms, so we see a lot of the same symptoms. So fever, runny nose, sore throat, wheezing, and we see less of vomiting and GI type symptoms when it comes to RSV, but it really doesn't mean that just because those are there that it's not from RSV. And really the bottom line is that the only way to distinguish between all of these symptoms is really by testing. So if you work in retail, I've probably sent you, and you're in San Diego, I've probably sent you one of my patients to try to pick up a COVID and flu test because it's really helpful for us if patients have that at home, and I actually advise them to try to do that. If they can test, because there are readily available COVID and flu tests. There's one for RSV, not as readily available, but when we can distinguish which one it is, then that's very helpful. And it's also, again, important to note that you can't really reliably tell what someone has unless you test for it. And part of why that's important, again, is because we can treat people that are higher risk for COVID and flu respectively, but for RSV, there's no readily available antivirals in adults. And so that's a point that we want to make because it's important to prevent, all the more important to prevent RSV. And so moving on to talk about the burden of disease, it's really important to know why we want to protect people because it does have effects. So when we say attack rates, which is the first point on that slide, essentially, very simply, that's RSV is circulating in a community, how many people are going to actually get the disease? That's what we mean when we say attack rates. So 2 to 10% in older adults are going to get sick with RSV, and you may say, well, 10%, that's not a lot, but when you think about the entire population, you can see at the very bottom of that triangle that people that have symptomatic disease tend to number in the millions. So over 2 million people can have symptomatic illness. That percentage is a little bit higher in people that are in congregate settings. So if you have people that live in SNFs, they tend to be gathering around each other, and so those attack rates are higher. And then moving up that graphic, that triangle, people that actually need medical attention, up to 1 million. So over 500,000 to 1 million people need medical attention. So think about our hospitals, our ERs, our urgent care facilities. Those are all people that are utilizing those really, really limited services. A lot of times when you see them and you're treating them, that could be because they have RSV. And hospitalizations, again, over 170,000 people a year are going to have this. And again, I should say that that's in the highest risk population of greater than 65 years old. That's who that graphic is referring to. And then you have over 10,000 in that age range that die from this. So it really is important to prevent it. And then in terms of mortality, when we see people die from RSV, it tends to be in adults greater than 65 years of age. 78% of mortality is in that age range. So again, as we talk about vaccination, always keep that in mind because we really are focusing on adults and that age range so that we can prevent deaths in this population. And of course, the disease burden is underestimated. Again, we don't have readily available tests, and also just in general, it's expected to increase because that population is, of course, exploding. We're going to have a lot of people that are aging into that population. And then this is a slide that tells us that in terms of non-hospitalization visits in children under the age of 5, we have about 2 million outpatient visits. And of course, this is a talk about adults, so why are we bringing up kids? Well, because people that are 65 years of age and older are grandparents, they're great-grandparents, and so they're interacting with children in one way or another. They're their family members are living with them. So it's important to realize that, yes, this is a disease that affects very young people, but also a lot of the transmission can occur because of that from the very young to the very old who are very, very susceptible. So it's important to keep that in mind as well as we talk to people in that age range. You may say, you have grandkids, you know, this is something that can make you more susceptible potentially. And of course, again, most people tend to recover, and that was sort of a theme, you know, in terms of flu and COVID. A lot of the conversation that we would talk about in the media was, well, it's just a little flu, and people are just going to get better, right? Well, not everyone is going to get better. So in terms of people that are in that age range, the biggest thing is not just being lucky to get there, but you want to have a good quality of life, right? It's the same reason why I say to my patients, we got to get your blood pressure controlled, because the things that are, yes, you may be there, and you may not die from it, but you can really have things like breathlessness, low oxygen levels, and complications from pneumonia, and functional decline, falls, all the things that we know affect quality of life for people in this age range and can really, really affect them in not a very good way. And then, of course, this was just something to, again, highlight the fact that in terms of those underlying conditions that are known or unknown, having RSV infection can actually worsen them. So there was a study that was done in over 6,000 people that were hospitalized with RSV infection, people that were 50 years of age and older, over 5 RSV seasons, and 22% of them experienced an acute cardiac event. Most often it was heart failure, ischemic heart disease, and it seems that people with RSV infection tend to have a higher mortality from cardiovascular disease exacerbation. So again, you know, this is something that can really have really deleterious effects over time. And what I found was really interesting was this report of over 5,000 adults that were in that 60 years of age and older age range. When you compared people that were hospitalized with RSV, COVID, and influenza over less than a year, we saw that the risk of ventilation or death was 1.3 times higher for RSV versus COVID, and actually twice as high for RSV versus influenza. So essentially, RSV should not be taking the back seat to these other viruses, right? Even though, you know, again, those have been so much in the media and continue to be, this highlights the fact that RSV can cause its own severe issues over time. And then in terms of treatment, so that's another thing, because patients always ask me when they've been diagnosed, well, what can I do? Give me some medication for it. There's no antiviral. There's no role for monoclonal antibodies in adults. We do have that in pediatrics, but we don't have that in adults. And we also, you know, treat underlying conditions like heart failure. They may need diuretics, they may need steroids if they have an exacerbation of their lung function, but it's really mainly supportive. So again, that's, you know, why I'm really passionate about preventing this, for this reason that there's no real good treatments. There's no specific medicines to target it in the adult population. So just some key points to take away from this intro. Remember that it has seasonality, so it is a virus like COVID and flu that we tend to see has seasonality to it. And then it starts in the fall, peaks in the winter time, similar symptoms to those of other respiratory viruses, and always emphasize that some people do go on to develop complications. Not everyone's just gonna have a cold and just get better from this. All right, so we will talk about some patient perspectives and listen to some of those experiences that patients have had with RSV.
Great. Thanks, Abby. So we'll go ahead and, you know, I think it's really important to put a face to a disease. Oftentimes, we go through a bunch of statistics, but for patients, for your patients, for you, sometimes it helps to see the real face of a disease. So let's go through and we'll watch a video here.
I understand that recently you were in the hospital with respiratory syncytial virus. So can you tell us a little bit about your background, medical history, any underlying medical conditions that you have?
I do have some COPD, but beyond that, no particular issues.
All right. And does it tend to bother you, or are you fairly active?
I am fairly active.
Okay. And I see you're wearing oxygen now. Had you been wearing oxygen prior to this illness?
No. When I went into the hospital with the RSV, they prescribed oxygen, and it has continued as I've come home. I just woke up unable to breathe. Got on a albuterol mist, and that quieted it down some, but I said, take me to the hospital. So I went into general by ambulance, and they did their thing for 3 days. The RSV was the worst.
Okay.
I mean, it closed me right up as far as breathing.
Mm-hmm. And how's your strength and your just general?
Oh, I don't think there's any question that I'm weaker. Mm-hmm. I definitely have lost weight. I'm probably down 7-8 pounds since the onset of this.
That B-roll was dramatic.
It
Yeah.
was.
What stood? Did anything stand out to anyone about his specific story? Anything? Any clinical symptoms or something that you were like, wow, that stood out? Complication. Anything for either one of you that stood out to you?
Yeah, we talked about weight loss. Like, he lost quite a bit of weight. That was something that you had brought up, which is really true. Exactly right. You know, someone who didn't need oxygen, and now that's such a great point to bring up, and now has this dependence on it. So quality of life, you know, these viruses are not just benign, especially in someone who is high risk. I believe he said that he had a pre-existing lung condition like COPD. Those are people that you want to target. So when in clinic, even pre-planning a patient that has asthma, COPD, you know, we're always looking to say, have you had all your shots? Because again, we tend to see it in people that are higher risk.
I'm also thinking about how he woke up and said he was unable to breathe.
Yeah.
Makes me wonder and he had COPD but didn't have much limitations. So did he have less lung reserve, and then all of a sudden just pretty dramatic?
Yeah, he said it was the worst, and I agree. It can be the worst.
Okay. Let's try another one.
3 weeks ago, I met you in the emergency room when you were diagnosed with RSV. Had you ever heard of that virus before?
Never, no.
Okay. So when we met in the emergency room, what was the primary reason you were there? What was wrong?
I was having a problem with breathing, okay, which was very scary, okay? When you can't breathe, believe me, it's scary.
You were in the hospital, I think, about 2 to 3 weeks.
Yes, you're correct.
So it took that long for you to start feeling better enough?
Yeah.
Yeah.
Jeff, this makes me think of something you said earlier, is only recently have people started to hear about RSV, even though it's been around for decades.
Yeah. And that sort of stood out here is he'd never heard of RSV, right? Which means that your job is to first educate before they even know why they're preventing something, right?
Absolutely, yeah. I mean, I would say 9 out of 10 times when I bring it up to my patients, they ask me what it is. Certainly, like you were saying, in the pediatric population, I think that there's more knowledge, especially because kids are so affected by it when they really get sick. So, but when it comes to the adult population, they always look at me and say, "What is that?" They're not even aware of it. So that's quite common for me in terms of a response.
For sure. The amount of questions we would get from people when media headlines were inundated with respiratory viruses is people asking, is this a new virus? Did RSV just kind of show up? And we're like, no, it's been around for decades.
Yep, absolutely. I think one of the exciting advances is that we have a way to prevent it in adults that we never had before. So disease was there, but there was little we could do. Right? Okay, let's try another one and expand it to our family here.
It started on Sunday afternoon, and it acted like a sinus drainage. And so I didn't think anything of it. And then on Monday, I started being shortness of breath. And so I went to the doctor on Tuesday, and she gave me albuterol. That didn't seem to work. And Thursday night, I went to the emergency room in Rockport. They sent me to Strong, and I was there for 6 days. And
that's where I met you.
Yes.
So I noticed that you said you were on albuterol. Were you wheezing?
Yes, terribly.
Do you have any underlying lung problems, asthma or emphysema?
No.
Okay, so this is something pretty different for you.
Yes, it was.
Now I see these lovely looking little kids here. These are your great-grandchildren?
Yes.
And had they been sick as well?
Yes. The week before I had this, they had ear infections, all 3 of them.
No.
They had their runny noses, their cough, along with the ear infections, and we think they might have had the RSV and we didn't know it.
Yeah, probably.
And
all around.
Yep.
So you were in the hospital for 6 days. How long did it take you to recover once you got home?
2 weeks.
Okay.
I was tired, I was weak, and all I seemed to want to do is sleep.
Yeah. Are you feeling all better now?
Yes, much better.
I'm so glad to hear that.
Interesting. Just looked over, he disappeared.
That was quick. I love it.
So I think it's interesting. I wonder maybe if you comment maybe on some patients, Abby, you see. I saw this a recurring trend, both in the first patient and this one, albuterol not working.
Yeah.
Wheezing, right.
Absolutely.
Which might have been, first go-to whenever you hear wheeze, but not working.
Yeah,
the
it doesn't always work in RSV just in general. But I also thought that, obviously it was such a sweet video. The little girl was really adorable. But the other point is, of course, being around kids, right? RSV is one of the most common causes of hospitalization in children under 2 years of age. So they're getting infected with it, very common, and they can pass it on to their grandparents. And I think that was probably what happened. The kids were sick first, and then she got sick. So again, important to tell them, hey, make sure you're protected because you may get exposed to this without realizing it.
I was just gonna say that little girl looked guilty. She knew it too. She was sitting there and she was like, I did this. Which is why, you talk about these cases in pediatrics, and to your point earlier, Abby, it's not just about life or death. So people are like, oh, so-and-so got RSV, but it wasn't a big deal because she recovered. And I'm like, but how many people did this child or this individual or someone who was sick but couldn't take time off of work, how many people did they infect and who was high risk? So there's a chain of infectious disease here.
Absolutely.
And I think it's interesting that the children sounded like very mild disease, but that same virus caused a very severe picture in the grandma. So it's not as if they're getting different strains. It's the same one. It just has different presentations.
For sure. Well, I want to get some input from the audience real quick.
Hit the button.
So quick show of hands. My farm fam. Show of hands, who has spoken to someone, could be a colleague, family member, anyone, about the RSV vaccine? Show of hands. So almost every table in this room, except for the middle table,
Great.
I wonder what y'all work in, has talked about it. So I want another question. I want to hear one word that comes to mind that you hear from patients about the RSV vaccine. One word, and I will start. Skepticism is what I hear, oftentimes with people. One word.
Confused.
Confused? Anyone got a word?
Suspicious.
What was that?
Suspicious.
Suspicious. What over here? On one word.
Scared.
Scared. This is very optimistic.
Political.
Political. We're getting warmer.
Unsure.
Unsure? All right. We're going with it. What about over here? One word.
Why?
Why? Well, sorry, whoa.
Nonchalant.
Nonchalant. So no one is excited or saying, yes, we need to get this done. So here's another question I have. What do you hear? What are the misconceptions or the thoughts or the questions you actually hear from patients? You said why. I'm curious.
It's funny, I've actually had patients who are not the population that should be getting it, who want it more than the population who should be getting it. So that's probably the most interesting thing that I find, is that the younger generation, you know, people in their 40s and 50s are like, can I get that? And people in their 60s are like, another vaccine, really?
That's fascinating. That makes me think there's confounding variables. Maybe it's health literacy, maybe it's people paying attention to awareness and should direct on where we're going with our education. Who here has something they've heard from patients about a question or a perception or something? Anyone here have an example? Something they've heard?
There's someone right in the front.
Where?
12 o'clock.
12 o'clock. Super curious. What is something that you've heard?
I was just going to say people are much more likely to get the vaccine if you let them know it's going to keep them out of the hospital, or more likely to keep them out of the hospital, that is.
So like an incentive, which goes into my next question of what tips or what has worked in talking to people about the RSV vaccine?
I think that just educating people about what's going around in your own community is really helpful, and helping them to understand, you know, we have a really great healthcare system as far as if somebody gets sick, they can go into the hospital, get treated, and be fine. But in those chances, in those situations where the hospital system is overwhelmed by, say, like an influenza A outbreak running rampant, that's going to occupy most of your hospital beds. So whenever somebody shows up with a really bad case of, say, RSV, there's not just like a whole lot of room for them, and that scarcity can be a little bit scary, and sometimes they don't have any idea that it's going on. So the more education you can provide about what's going on in your community is really helpful.
Are you an educator? Do you work in communication? Because that was fire. I mean, people, I hate to say it, are inherently selfish, but when you show them that there's a public health impact or there's an indirect effect, to your point, I think it does make a difference. Who over here has a tip for the up-and-coming educators and communicators of the world? Bring the noise. You can answer whatever question you want.
Okay. Well, I think it helps to personalize it to the patient. So like in the case where that person had COPD, you could say, because of this, you know, and bring it home to them.
Meeting the audience where they are. Amazing. Before I toss back to our experts, I'll tell you the one thing that's always worked for me is I often hear, well, why is the vaccine coming out now? Are you guys in bed with pharma? Who's doing it? Is it political? And to explain to patients why it's taken so long to develop one, kind of unveiling that scientific mysticism helps as well. We have a lot to talk about. I'm excited for our next round of audience interaction because this group is engaged. Don't worry, I'll bother the next side over there next time.
Okay, there we go. Okay, so now we're going to dig in to some of these vaccines, right? And unlike a lot of disease states, when they first come out, we only have one vaccine. We actually have 3 vaccines in this space. So lots of choice, lots of decisions to be made. So let's talk a little bit about what we have and how to make them. As mentioned before, this is our RSV vaccine, right? In the family, right, there's family, genus, species. I think it went a little bit further up the line. But this is Pneumoviridae, and it's a negative strand RNA virus, right? But the key part is the surface protein. So, you know, for example, in influenza, we target the hemagglutinin neuraminidase, that's the H and N. For RSV, we're most concerned about the F or fusion protein, because that seems to be the one that your immune system likes to target. And so that's why vaccines are developed against that. And more specifically, in what's called a pre-fusion conformation. So that's why you'll see the name of the vaccines being pre-F, for example, meaning pre-fusion. This is what we have, right? So we have a couple things to think about in our adults over 60. We have RSV vaccines, and we're going to talk about those 3 in the next slides here. Who's it recommended for? Remember, we changed the recommendations more recently so that for 60 to 74, it's increased risk. So all those risk factors that Abby talked about are our risk factors that we consider when giving the vaccine to this population. And again, we follow CDC recommendations, which start at 60 right now, and I'll talk about some FDA coming in here, but I thought it was interesting when someone said that people who are not indicated the vaccine want the vaccine. And it reminded me a lot of when COVID first came out. I was on one of the working groups for creating the prioritization, and we had vaccine chasers. So it turns out when people can't get something, they want it more, right? I don't know why, but if they can't get it, they want it. Okay, and then everyone 75 and older, right? Age-based recommendation, much easier to think about, right? Now for babies, we brought it before, we do have two options depending on the status. So our first primary option is to vaccinate mom, right? So if we can get vaccine into mom on time, then baby will be born with antibodies on board, right? If we can't, then we have nirsevimab, which is the monoclonal antibody that works right from birth for those infants that the mom couldn't be vaccinated, right? But the vaccine is not used in infants, right? So the vaccine is an adult vaccine, but the monoclonal can be used in infants. And we'll talk a little bit about the seasonality coming up. Okay, so these are our three vaccines. We have two protein-based vaccines. One's adjuvanted, so that is the RSV pre-F3, or the RSV. And then we have a bivalent RSV pre-F, bivalent but still 2F pre-fusion proteins, right? And that's a Abrysvo. And then we have an mRNA vaccine, which is Imresvia. Right? Now, if we look across the FDA indications, and it's important to kind of remind people, the FDA makes indications, the CDC makes recommendations. They're different, right? Now, the peer standard is the CDC. Sometimes the FDA doesn't like that, but the peer standard is CDC. So if we look here, under FDA approvals, right, we have, for example, for the pre-F3 or the RSV, everyone over 60, right, should get a dose. We know that. Now, it doesn't delineate 75 or high risk. That's not the CDC's job. They do safety efficacy. That's how they approve vaccines and medications. CDC then adds some more nuance to recommendations. But on June 7, the FDA approved for 50 to 59 years old for RSV and for 18 to 59-year-olds for the Abrysvo. All right. Now, if you've been watching the CDC and what's been going on, they missed a meeting in February, mysteriously canceled. Right? So that's when they were supposed to consider these new age ranges that the FDA has approved. So currently, there is no CDC recommendation for anyone less than 60 years of age other than pregnancy, which I'll mention in a second. So we have to wait for the CDC to come in before most places can use the recommendation. Again, most places wait for the CDC for their recommendation. Now for pregnant individuals, remember it's 32 to 36 weeks gestation. It's different than Tdap. Tdap goes down to 27 weeks. But for Abrysvo and only this RSV vaccine, that's where you want to target giving the vaccine to patients so that in anticipation of RSV season coming up, when baby's born, that they'll have protection during the season. And remember, our season usually goes to the end of January. I think I have a slide for that too. And then Imresvia is our newer vaccine that just was approved, and it's for 60 plus, but again, it follows the CDC recommendations of 60 to 74 for high risk, and then 75 plus for everyone. Okay, so now let's see, where do these fit in? Because practically, you have to figure out when to give it, right? The RSV vaccines, right, really sort of line up along the month line. So if, for example, again, unlike influenza, which may come out in July, right? You may have influenza doses in July. The RSV vaccine is already available. It's always available, right? So you don't have to wait for it. But starting in August through October is what we call the optimal time to vaccinate. And again, this is one time, right? So right now, the indication and the CDC recommendation is for one dose only for people, right? So during this time, to maximize its potential to protect people, we vaccinate August through October, and then peak RSV season is generally in the Northern Hemisphere, December through February, right? Now, can disease occur anytime during the year? Absolutely, right? But we know that peak is around December to February, so if we're trying to time the vaccine, which we know, like all vaccines, their immune protection begins to decay after you give it, right? It doesn't go up anymore. It just goes down after that. We're trying to maximize that immunity right after vaccination, right? And so this is for our 60 to 74 and 75 plus. It looks very similar for pregnancy as well. But again, we're trying to maximize that 32 to 36 weeks, right, to get them vaccinated. But we end vaccination for pregnancy in January, right? Okay, so what happened from CDC? Everyone likes changes. You think it's hard to explain to somebody a recommendation, and then it gets changed again the next year. And you're like, okay, so now it's this, right? Well, what happened was, in 2023, we had a recommendation for the 2 available vaccines, right, which were the bivalent and the adjuvanted vaccine, the protein-based ones, for everyone 60 and above, but by shared clinical decision-making, right? How many of you like shared clinical decision-making? I can't see if anyone raised their hand. Yeah, like, well, I don't know. It's hard to implement, right? Because unlike a recommendation, you can't target people by disease states or by age. You just have to have a conversation with them. That's what literally shared clinical decision-making means, right? Is that you identify a patient you think would benefit from the vaccine, now you have a conversation with them, and they decide to get vaccinated, right? Very hard on a system level to implement. So in 2024, July, the recommendations were radically changed. Now, it used to be, I heard at a previous presentation, people complaining, you know, they used to be indicated to get it because it was shared clinical decision-making, so that really allows almost anyone to get the vaccine that you decide to give it to over 60. But now we went to more strict recommendations. We changed a bit the high-risk conditions, right? And now it's age 60 to 74 who are at high risk for disease, and the key word here is should receive. CDC likes to introduce new terms. Sometimes they want to subtly nuance something, but it's really hard to nuance a public health recommendation, right? So they use words like may and should, right? I don't know what that means to you. It's like may, right, means, I don't know, maybe I don't have to do it, right? But should sounds like you need to do this. Right? Be better if you just say you need to get this, right? Make clearer language. But unfortunately, we're dealing with a little bit of ambiguity, but that's what they're trying to say, is that everyone should, right, get the vaccine now in this age group, either 60 to 74 with high-risk conditions or 75 plus. Right? Which is interesting, we chose 75 plus. It's the only vaccine the first time that we have used 75. Right? 65 has been the highest that we've had before. Now we're up to 75. They'll have to add another column to the adult immunization schedule, right, because it ends at 65. And interestingly enough, the life expectancy of people in the United States, anyone know what it is? 78. So you got a good 3 years on this thing, right? By the time you get universal recommendation in here. Okay, so why did they do this? Right? So this is the CDC's rationale for that 75 plus. First, it makes vaccines a default, right? So when you do age-based, you don't have to figure out what disease states they have. All you have to know is how old they are. Right? So it makes it a lot easier to program pharmacy systems or EHRs. Easier to incorporate to standing orders. Depending on your state, you may use standing orders, and those things are a pain in the butt to modify sometimes, depending on how prescriptive they are. But that also goes for nurses who are working under standing orders. So there's a lot of things to incorporate when you use clinical decision-making in a standing order. Now, it also covers those at highest risk without asking providers to do extensive individualized risk assessments. So now you can just use the diagnosis. You don't have to go through and do a risk assessment. Now, on the con side, right, what's the negatives? It's a universal RSV recommendation, but only for 75 plus. Right? So we kind of lost the universality of it being 60 plus, right, under shared clinical decision making. There are, ongoing challenges, complexity of the adult schedule. The pediatric schedule has a whole bunch of columns, right, for age breaks. And we used to say the adult schedule, I remember when it only had 3. Right? Now it's got a lot more, and it's going to add even more columns to it, which makes it a bit more complex. And of course, there's the old problem of if you keep changing things, how can we trust you? Right? So, and again, trust goes to you, because you're the one who's trying to explain to them that now you need the vaccine. It's kind of like dropping the pneumococcal vaccine. You're like, I thought it was at 65. Now I need it? Right? Yes, it just changed. Right? Okay. How about for the 60 to 74? Some things to think about. It is risk-based, so that is easier theoretically than a clinical shared clinical decision making, right? So again, it's a should, not a may, and easier to incorporate, especially in more sophisticated systems that can identify disease states and then automatically flag that person for vaccination, right? Risk-based recommendations, though, are still more challenging. So people ask, well, why didn't you just make it 60 up and everyone get it, right? And the answer is economics. It turns out it's more expensive. When you look at the qualities, which are the quality-adjusted life years, it doesn't make sense to money-wise to offer to everyone because they won't benefit as much as those who have highest risk conditions. So they're trying to use the resources wisely, and that's why they come up with more pinpoint recommendations for the 60 to 74. These are the conditions, right? And I think some of these that changed a bit when it went from shared clinical decision making, like in type 2 diabetes, now they're looking for more extensive end-organ damage. So for example, CKD, neuropathy, retinopathy. So it's not just having diabetes, it's also having end-organ damage associated with it. That changed from the clinical decision-making model when it was 60 plus, right? But people who are on insulin, they do consider that as enough of a recommendation that you could still give them the vaccine in the 60 to 74-year age group. And of course, there are a lot of other, these kind of tie into the high-risk conditions that Abby talked about before. So just keep in mind there are a lot of conditions that would indicate your patients, but it's hard to remember all these in a single thing when you're trying to review a patient coming through. So having systems to help flag them will help you tremendously. Okay, let's talk a little bit about how well they actually work. Right? Does anyone know the difference between efficacy and effectiveness? Is this just like a nerd difference that we have to know? Right? It is sort of, yeah.
Someone raise their hand.
Oh, can't see. Absolutely.
Boom.
Well said. Yeah. So in case you didn't hear it, what it was, efficacy is how well the vaccine works in very controlled clinical trials, and effectiveness is once we unleash it in the public, how does this thing actually work, right? And finally, we do have some real-world data. Now it's limited, less than 1 year, because again, the vaccines are new, and we don't have effectiveness data for RSV, the mRNA vaccine, because it's way too new, right? So what this is looking at is a comparison of some efficacy data, which is in the top in blue, and effectiveness data, which is down below. So looking in some of the two protein-based vaccines, you can see that efficacy went anywhere from 67 to 86%, right? So there was a range depending on how sick the individual was. Turns out the sicker they are, the better the vaccine works because you have a more likelihood of impact when they are more critical. Now, if you look in the effectiveness, we have many, many systems in place and data sources to draw from to do some of these control negative type designs to see if the vaccine is working in the population. And the good news is it does hold up in the effectiveness. So you can see down there that we're anywhere from a low of 72 in the Medicare data all the way up to 80 and 83 in some of the other Medicare databases, right? So the effectiveness is holding in there. That's the good news. Okay, what about durability? I'd start out saying this is a one-time shot, right? You get one dose, whether you're pregnant, whether you're an older adult, you get one shot at this, unintended. So in which case, how long does it last? Right? So this is some initial data that came in. And it turns out it does have the higher efficacy is within the first year, and actually really within the first 4 months is when you get the peak efficacy, which means timing it with the RSV season does make a lot of sense, right? But beyond that, it still does maintain efficacy. For example, you're looking at beyond 12 months, 13 to 24, up to 30 months in one of the RSV trials. So we are getting data showing that it is holding in there, but certainly lower than it was when it's first tested, right, within the first year. What the CDC is waiting for is even longer term data before they make a decision on whether you need another dose, and if so, when. So when you're talking to patients, usually what I say is the recommendation now is that you get one dose, right? Leaves the door open in case it changes, right? Okay, now the flip side, and this is maybe where some of the people get concerned about, is the vaccine safe? Right? I know around the mRNA vaccine for COVID, there was a lot of talk about how safe the vaccine was. It's a new vaccine. We don't know what it does. And the CDC put together a lot. For example, vSafe was really invented just for the COVID vaccine. Right? So we had so many safety systems in place that we can detect signals early to be able to protect people. We are so lucky in the United States to have the safety system we have in place for vaccines. We have nothing like that for drugs, right? There's nothing anywhere near the type of safety system and surveillance that we have for vaccines. But let's talk about oriented news. There is a safety signal that came out. So all of our great systems do detect, and that's what we hope they do, is detect any safety signals. And there was one detected with the 2 protein-based vaccines, so there is RSV and Abrysvo, for Guillain-Barré syndrome. Right? Remember, this is a demyelinating disease. It can cause partial paralysis. It can be short-term, long-term, and very rarely do people die from the disease. But it's not just from vaccines. For example, Campylobacter jejuni probably causes a greater percentage of the GBS that we see. However, we also see it more in older, so in men and people older than 50 years of age, but not just the RSV vaccine. So also in influenza, COVID, RSV is the zoster, is the shingles vaccine. So there are other vaccines that we're concerned about. 42 days is that critical time period that the FDA monitors and can assume that if something occurs within 42 days, looking at the biologic basis, the causality, they're more likely to associate it with the disease. Anything beyond 42 days is unlikely to be related to a vaccine. So that's an FDA standard that CDC also uses. Data was updated, and what we saw now is now we have more doses. So we started off with data in June for about 1.3 million doses. That went up now to 3.2 million doses in October, and we saw more GBS cases. Right? Now, still, compared to other vaccines, compared to bacteria like Campylobacter, it's at about or less than those, but it's at a safety signal level that an alert was generated and an FDA advisory went into the package insert to alert people to look for GBS in patients. Right? Now, if someone gets it, they have Guillain-Barré, then you don't want to they wouldn't get that vaccine if it had a subsequent dose again. That's the sort of the practical take on that. Right? But it is something the CDC will continually monitor. In April, we'll probably get it. That's when the next CDC meeting is supposed to occur as a replacement to the February. That we should get an update on safety of the vaccine to see if the signals still hold true as we have more and more doses being given. Right? So this is an ongoing issue that we're watching. We don't see it yet with the mRNA vaccine, and that just might not occur with this vaccine, but it also is new and hasn't been out there long enough to really study it. Co-administration. Right? Now, you probably give a lot of vaccines together. We recommend that the way all vaccines should be given at the same time, right? You might have to dispel some myths about can you give vaccines at the same time? The answer is absolutely yes, right? Because if you give one and it hurts, and you have another one to give, and you go, come back tomorrow, what happens?
You're not coming back.
They don't come back tomorrow, right? So give them all at the same time. Right? That way you know that they're going to be protected walking out the door. Now, there was some data that came out looking at the RSV vaccines in concomitant administration with some more common vaccines, like, for example, influenza. The only place that it met what's called non-inferiority. The non-inferiority standard is set by the FDA that says that if it is non-inferior, then it should be considered the same, right? But if it's not non-inferior, right, I know that's a double negative, right? Then there should be a caution associated with it. So here's what happened. In the adjuvanted influenza vaccine, right, and so looking at the GSK vaccine over here, right, that's for the flu, because the adjuvants are similar, both the GSK vaccine has an adjuvant and the adjuvanted flu vaccine, right, we consider high dose, also has an adjuvant. What we saw was that the H3N2, not the H1N1 titer, but just the H3N2 titers were inferior with co-administration. Not to the level that the CDC is changing recommendations. Same thing down there with high-dose influenza and the mRNA vaccine. Co-administration didn't meet the non-inferiority criteria. What they saw was the neutralizing antibodies, those antibodies that should inactivate your virus, for RSV A and B, were inferior with co-administration of the high dose. Right? Now, oftentimes, these are lab, either anomalies or something that needs to be followed up on. But currently, the CDC has not changed their recommendations. So they don't believe this data is compelling enough to change their general recommendations that all vaccines can be administered simultaneously. Right? So that is the general recommendation that has not changed, even though there is some data that suggests that maybe, right, there may be some decrease in efficacy of one vaccine or another. But what we don't know, is it clinically relevant? And that's why a lot of these recommendations or this data that we see in co-administration doesn't change our recommendations because we don't know if it's clinically relevant. Right? And this is only flu. We didn't look at pneumococcal or other vaccines that you may be giving just routine during that time. So a lot of vaccines don't get tested with co-administration, but we still use general recommendations. Right? Now, switching over to you, right? This is, as the pharmacist, you are busy. Right? This is looking at NIST, which is National Immunization Survey, doses administered calculated, right? Versus IQVIA, which is an EHR service. They scrape data from electronic health records, right? And what it's looking at is doses administered by pharmacy, right? Now, there's a little discrepancy between the doses because one's calculated, one's more actual. But I think this slide sort of sells it, right? This is who's getting the vaccine, right? So if you don't get the vaccine, in other words, you don't get it shipped to you, then you're not administering it. And we can see that most vaccine is given and administered in community pharmacies, the vast majority. And in fact, it hasn't changed since when the vaccine was initially released, back there in 2024 is when we started measuring this, all the way to 2025, there's really been no change. So on the medical clinic side, it hasn't picked up. Okay, so this then gives us some opportunities, right? For example, how to navigate going from shared clinical decision-making now to a general recommendation. How do you counsel on Guillain-Barré syndrome, right? And how do you discuss co-administration, right? If for some reason the data gets out there, although that data almost never makes it to the public, but if you get someone who read the internet, right, then you need to be able to answer and respond to their question about co-administration. Okay, let's... I'm going to throw it over to Alok now.
So I should not be this excited about the myth-busting portion of this, but here I am, and here we are in 2025. So we're going to read a myth. I'm going to have everyone think about what the right answer might be, even though it says myth, but think about the why, and then I'll toss it over to both of you. So first myth, only infants are at risk for severe outcomes. I see a couple heads already shaking, and you did see some patient videos earlier that gave you the answer, but what do you both think about this?
Yeah, definitely not true. We obviously see that actually most of the mortality from RSV is in older adults, so not true at all, and so it's important that we communicate that. But of course, it's also important to remember that we do see, even in adults that are not necessarily in the 65 and above age range, if they have underlying conditions, they're also at risk. And there's not a vaccine recommendation in that age range at this point, but it's definitely not just in infants.
This next one kind of hints at something Jeff mentioned earlier. You can only get RSV infection once in your lifetime. People aren't even impressed by this one. Jeff, what do you think?
You can get it more than once, for sure.
I have a 4-year-old who could answer this question. She's like, yes, you can. If you got your flu vaccine, you don't need to worry about RSV. I know, health literacy differs in the country. Some people don't know it's a different virus. Yeah, I mean, yeah, anyway. This is an interesting one. For adults, one vaccine is recommended versus others.
Yeah, this is the part where I, get people, or the part that reminds me of people that come in nowadays and say, well, I've done my research, and that's something that we're all going to get thrown at us, right? People doing their research and trying to decide which ones they're going to get. So it's definitely a myth, and it's important to remember that the vaccine that's available to you is the best one to get. There haven't been those head-to-head comparisons, and so we recommend them if they're looking at the numbers and one's higher when it comes to the efficacy or effectiveness. It's not really true that it means that these vaccines are going to work. One is going to work better than the other. So it's important to communicate that.
I think there is one. We have a bunch of pharmacists, right, who like to go, we're the exception to that. There is one adult population where there is only one vaccine recommended.
Yes.
Pregnancy, right? Yeah.
Smart group here. Okay, so I want people, not just related to RSV, it could be any vaccine. Somebody tell me a misconception or a myth they've heard about vaccines in general. Could be anything you want. Microchips. Oh my gosh. Microchips in the mRNA vaccine. Thank you.
That vaccines contain like a dangerous amount of heavy metals and aluminum and stuff like that.
And we get more aluminum from breastfeeding. What a fact.
Vaccines make you sick.
The vaccines make you sick. Maybe a misinterpretation of side effects, adverse events that we suspect.
Go back to the classic that it causes autism.
That we are still having conversations about. I'm trying to be really nice right now because I'm on camera. Now, what are the ways that you all have addressed some of this? I know we talked earlier, so I'll be quick, but perhaps with a family member or a friend. Are there any general themes that kind of help you in having these conversations? I'll take like 2 and then we'll go back to our experts. Anyone? Anyone have a conversation with a friend, social media?
Just ask them, why would they put microchips in it when you carry your phone everywhere? They can already track you.
I like that. I like that. Throw logic. So basically you're explaining to people like there's an easier way to do it, and then you find that works.
Yeah, actually, they're kind of dumbfounded.
Last one, anyone else have like an approach that works in addressing people who believe something so intently that's misinformation?
So I tell patients, where did you hear that from? Why do you believe that? Is your information accurate? What about my information? Is mine better than yours? Like, which one's right? And then I start having them second doubt themselves, and it just spirals from there.
Teaching people how to vet their information. Anyone got one last one? Oh yeah, I knew someone did.
I literally just put a magnet to my arm and showed that there was not a magnet inside of me that attracted the vaccine, so that proved that there's no microchip.
And that goes down to the individualized answer. How many people in here are students or trainees? I would imagine that this is all changing as I go back to Jeff in terms of your education and what's being talked about, because it is just a rising issue and there's a lot of combating this. So I'll pass it back to Jeff to talk a little bit more about strategies, awareness, and where we go. Take it home, Jeff.
Yeah, I think I'll start off by people who are talking about, they have their own facts. One of my favorite quotes is a legislator who said, you're entitled to your opinion, you are not entitled to your own facts. Right? So making sure that people can separate out opinion from facts is hugely important. And GBS is one of those where they may hear, that it's caused by the vaccine. Now here's where it's hard to tease apart science from fear, right? For example, if you ever tried to explain a p-value to someone, right? It's less than a 0.05. It's less than a 5% chance that it's due to that. So there's a chance. Well, no, not statistic. Forget it. You'll never win that one, right? So keep it simple when you're discussing the risk. And for GBS, it's something that we monitor. And you can look at the number of cases, right, are less than 100 easily for millions of doses being given. So it's still a very, very rare adverse event. And in most people, it doesn't cause long-term damage and it goes away, right? Duration of immunity is maybe a little bit more challenging. Okay, well, let me run through some of this so we can get to some of the questions that you might have as well. Duration of immunity, as I said before, it is an ongoing study, right? So at some point, when the CDC is convinced the data is there to support, for example, another dose, in other words, it's declined to a level that they think is no longer protective. It's a little difficult to figure out because there's no clinical correlate of protection, right? For things like hepatitis B, we have a clinical correlate of protection. We know if you hit 10 and above, you should be fine. We don't have that for most diseases and vaccines, and RSV is one of those. So it's going to take some time to figure out if we need another dose of the vaccine. That's still coming. And then last, the pediatric coverage versus adult coverage. So really we're talking, for pediatric, we're talking about moms, right? Those people who could benefit from the vaccine, and that's our women who are pregnant from 32 to 36 weeks, and if it's in season, right? So around the time when we need to vaccinate. So it's an ongoing challenge, adult versus pediatric vaccination, but I think you probably developed some strategies that work for you, and that's what we need to share, is what strategies are working. Right? There are some educational strategies you might think about, right? Some things in managed care that they do, leveraging clinical staff for outreach, getting as much education out there as you can, especially to communities where information is least likely to penetrate. Right? There are still some equity issues in vaccination and in vaccination rates, and especially in disease in communities, different racial, ethnic communities that don't go away because you stop talking about them. They're still there. Right? We need to figure out ways to make sure that we can get people vaccinated and protected regardless of the community that they're in. RSV awareness is low. So you can start by, for example, we do a really great job in the flu season, right? Those of you out there in community pharmacies, you put up like in-store advertising posters, the roll-ups, right? Do that for RSV as well. And maybe now you have like a 3-section. You got an RSV, you got a COVID, you got a flu, put it all on one so you get one banner in there. But in-store marketing has shown to actually work very well. Right? You may have the same experience. If people see it, they're in there, they're in the mood to get vaccinated, they might get it right then. Right. Prevention requires a team approach and resources. So we have lots of resources available for you to check out, from APHA, which has a whole immunization resource site, to our government sources, CDC, and CDC has many, many different references and resources for you that are still up. Okay. Racial and ethnic disparities, we talked about that before, and we know that the National Health Information Survey analysis, so the data in there helps to guide outreach programs, right? And there are lots of findings where we know there are gaps and deficits, and we know that vaccination rates are low, for example, in non-Hispanic Black communities, Hispanic and non-Hispanic Asian communities. We know that we can identify communities, right, that need your services. If you're in an underserved community, you know what I'm talking about, because there are myths that vary from one group to another. Right? So the same myth that keeps people from getting vaccinated might not be the same in our Asian community versus Black versus Caucasian. Right? They may vary. Okay, and of course, having health insurance has a positive impact because you can if you can use it, right, and get in there to get the vaccine. That's why our health maintenance organizations, HMOs, were a good idea. I think they're still a good idea. They could just do a better job at the prevention side, which is what they were invented for. Right? Vaccine hesitancy, we changed some terms, but instead of saying anti-vaccine, we call it vaccine hesitancy. Right? So CDC has kind of rebranded this to not label people, right? And to help people understand that most are on a spectrum of acceptance for vaccine. You know, at the very opposite end are the anti-vaccine, but most people are in the middle, and they can be moved with good, authentic information. They trust you, and we know that pharmacists are always in the top 5, the Gallup poll for most trusted healthcare professionals, right? Yep. So we want to make sure we take full advantage of that.
Before we go into that, to take a quick second, I have to reiterate the importance of something you mentioned about not labeling people who are vaccine hesitant as anti-vaccine, because we find that that turns people away when they just want to answer questions. You know, people might see something like Guillain-Barré syndrome. It's dramatic. They see a video and they freak out and they just want to hear that that's 1 in a million, but the rates of having a severe complication from a disease such as RSV is higher. Paul Offit, who sits on ACIP, has called himself vaccine hesitant when they get a new vaccine, because that is not a skeptical lens. That's a lens where you want to look at the data. So I think it's so important to reiterate that VHPs, vaccine hesitant parents, are not anti-vaccine.
So best practices to encourage vaccination in priority populations. These are a lot of different things that you may have seen, that you've used, but others have used, all the way from really targeting the message for your audience, educating on risk, leveraging trusted messengers. So that might be using the church, it might be a local group that maybe has a good reputation in the community, CBO, community-based organization that you can use. Simple language, right? Don't confuse them with a lot of facts. Keep the message simple, right? And that's what public health is. Public health is don't create a very complex message, otherwise it won't be acted on, right? And of course, sending follow-ups and reminders, because people forget. So use our technology out there to make it easy for people. I would say, why make getting a vaccine hard? Make it easy, right? So that they can easily walk in, get it when they need it, and it gets paid for, adjudicated, and it's easy to come back and get it. Right? That's what we want to do. So these are our pharmacists' role in vaccination, all the way from educators, as trusted healthcare professionals, screening. Again, we need to identify those high-risk populations for 60 to 74. We need our systems to work to identify those over 75. If your pharmacy system doesn't do that and doesn't flag patients, you're missing out on opportunities to vaccinate them. Promoting awareness, you can use in-store signage, use social media. I know, sounds scary, but ask your teenager. They'll help you with that. Administer vaccines on-site, provide convenience, so do it right there. Referring people out, you lose it. Even though from medical offices they may refer, but they know, and we know, sometimes people get lost in between their clinic and the pharmacy, right? And don't show up for vaccination. So wherever they are, vaccinate them. And of course, collaborate with other healthcare professionals. It's a team sport to get everyone vaccinated. Okay.
Thank you all so much for being here. Thank you both for taking the time. And with that, thank you all for being here. We appreciate you.
Nice job.